Okay, welcome to this session on the technological revolution in healthcare and the role of quality improvement. My name is Ruth Glassborough. I'm the Director of Improvement at Healthcare Improvement Scotland. I have absolutely no expertise whatsoever in technology, and I need to declare that up front. But I think the reason why I was asked to chair this session is because I am absolutely passionate about the role of QI and the need to significantly strengthen the role that QI is playing in the implementation of new technology. So in this session today, this is what we're going to cover. And my personal belief is that the delivery of health and social care is going to be transformed by the role that new technologies play, whether or not that's genomics, AI, robotics, wearables. We have, or it feels like we're on the cusp of quite a significant transformation. And for those of you who are sitting there thinking, come on, we've still got a fax machine in my organisation. You've been telling us this for years, but it's not going to happen. I think it is, because I think we've got what's coming together, I would say 5 key drivers right now. The first of them is the global workforce shortage across health and social care, and it is a global workforce shortage. If we don't start automating what we can automate, we're going to be in difficulties. The second is austerity, and whatever the political parties tell you, it is a spectrum of austerity. Under some regimes, it will be more austere than others, but when you look at global economics and the predictions around growth in the economy, there really is no option in which health and social care aren't going to need to find ways of doing things more efficiently. We also have a climate emergency, which is driving uptake of virtual healthcare. Big tech see this as a big business opportunity. I was fortunate enough this year to be over at Microsoft's headquarters, and they were sharing that in terms of their cloud, they're growing at 125% a year globally in terms of healthcare. So it's big business for them. Some of you who may be old like me may remember about 10, 15 years ago, we all heard how Google were coming into the healthcare market and how the big tech firms were coming in, and nothing happened. Well, Microsoft shared with us that they did try and come in, they did try and enter about 10 years ago. It went badly, they retreated, but they didn't retreat and do nothing. It went badly because they underestimated the complexity of healthcare, but in retreating, they've worked out how to do it, and they're now coming back with a vengeance. And then the 5th issue is more and more voters are digital natives, so they are going to expect our health and care system to be one that is using technology. So I do think we're on the cusp of something that's very different. And the reason why I think QI is so important is summarised by this diagram that we have stolen shamelessly from work in Singapore, that highlights that if we're going to see the kind of transformation that we all aspire to, we have to bring together the work around system process redesign, which has traditionally been the domain of QI, with the work around the implementation of new technologies, and then the work around workforce redesign. And wouldn't it be brilliant if the digital and the new technologies could be aligned with where we have workforce shortages? Wouldn't it be brilliant, actually, if we were thinking now about where the new technologies are going to replace staff and thinking about how we're going to train those individuals up in the areas where we have workforce shortages? The reality where I come from in Scotland is at the moment these things are in too much of a bubble. And the reality is that QI has a skill set that really does aid implementation of new technologies. And if we are going to survive, I would say, even as a profession, this is a space that we have to be in. So I am absolutely delighted today that we've got 3 speakers who have lived and breathed using QI to implement new technology. And they're going to share with you today their practical experience of doing it. So I think we're starting with Asma, who is going to start and come and talk to us about the work that she's been doing.
Well, thank you very much. Thank you for your kind invitation and good afternoon. So I'm an obstetrician, so I'm going to talk to you about high blood pressure in pregnancy. So preeclampsia or high blood pressure in pregnancy is one of the commonest causes of maternal deaths. But of those women who experience high blood pressure in pregnancy, less than 1 in 4 or 1 in 5 will actually develop hypertension in pregnancy or high blood pressure in pregnancy that actually could potentially harm the mother or the baby or requires medical intervention. But because of this potential risk, these women are advised to come to the hospital 2 to 3 times weekly to have their blood pressure and urine checked. So you can see these frequent hospital visits can cause anxiety to these women. They have to take time off work, arrange childcare and transport. And they're also expensive. I mean, expensive to the NHS, which is already financially struggling, and also expensive to these women. So we really wanted to come up with a solution which empowers these women to be involved in their own care, improve their experience, and reduce hospital visits. So we developed a system called HaMpton, or Home Blood Pressure Monitoring in Pregnancy, that was funded by the Health Foundation as an innovation grant. It's an online secure platform that has a patient interface as an app. When women actually input their blood pressure readings, it's transmitted in real time to the platform, so the doctor or the midwife in the clinic or the hospital can see these readings. The system is really user-friendly. It does have videos to teach them what to do. It also tells them whether the readings are okay and advise them to continue monitoring, or actually when they need to contact the hospital or the doctor or the midwife, or actually when they need to come physically to the hospital. We involved the patient at every single step during its development, from the early stage, and we really learned from this woman. We learned more from their negative feedback than the positive feedback, and we developed and improved the system taking into account this feedback. When you have an innovation, it doesn't usually sit on its own. It has to be integrated in a care pathway. So we worked with a clinical team at St. George's Hospital, where I work, to actually define who would be eligible to have the home blood pressure monitoring, who is not eligible, and actually really develop these pathways and test them and improve them. We conducted quantitative and qualitative studies, and because of the time, I'm not going to go through all of them, but really to summarize the outcomes that we saw, we had a very high level of satisfaction, both the patient and the staff. Patients really like it. And I do a lot of research. I've got a big research team, but actually, and not many things that change that you try to introduce. You find that your colleagues are welcoming it, but this is one of the things that actually your colleagues in the clinic call you and say, well, I have a patient, can we put her on the home blood pressure monitoring? We reduce the hospital blood pressure visits by about 50%. We reduce even the duration of the visit when they come. 2/3 of these women reported that they felt less anxious when they checked the blood pressure at home compared to when they do it in the hospital. We diagnosed a number of women with white coat hypertension. I was really surprised how common it was. This is a condition, if I check your blood pressure in the hospital, it's high, but if I check your blood pressure at home, it's completely normal. And you can imagine how much potentially unnecessary medical intervention that we do for these women because we don't know that they have white coat hypertension, particularly starting medication unnecessarily or even inducing labor. So far, we did not have any safety adverse events. We also found that the induction of labor was about 15% less in women who are on home blood pressure monitoring compared to those who are not. We also did health economics study in collaboration with the team in the University of East Anglia, led by Professor Richard Fortham. And the saving is about £1,700 per patient. If you scale that nationally, we have about 700,000 births in the UK every year. And if you use really a modest estimate of about 3.7% of women using it, the national saving is about £44 million every year. As I mentioned, we published a number of studies, and these studies did attract the attention of the scientific community. The journals have something called allometric score, and if you have above 100, that's apparently very high. These are some of the comments from the patients that used the system, and I have a video, if we have time at the end of my talk, I'd like to share. This is one of the patients that used HaMpton. We won a number of awards. So we won the HSJ Innovation Award in 2017. Something that I'm particularly proud of is the CQC. So the CQC, when they came to visit St. George's Hospital, they obviously published their official report. The hospital in general didn't do very well, but actually in the official report, they commented that on HaMpton as a successful quality improvement initiative. In fact, as a follow-up, so earlier this year, the CQC published a report on innovation in the NHS, and they actually commented really nicely about home blood pressure monitoring in pregnancy. So really proud. The HGA, when you win an award for the HGA, they share with you what the judges mentioned about your innovation. So that was aligning the need for a real focus on safety and quality for a very serious condition with patient views, clinical expertise, and technology. We've been on the newspaper when we published our studies because they felt that this was something important for the public. So the journey so far, we started back in 2014 when we got really a small grant from the Health Innovation Network. And that was really mainly to buy blood pressure machines that are validated, accurate in pregnancy. And there's only about 5 on the market. When we tested that, as I said, to my surprise, people really like it. So that encouraged us to go to the next step and apply for more grants. We got the Health Foundation to be extremely supportive to our work in 2015 to develop the system, to develop the HaMpton. We had about 100K. As in 2017, I became an NIA fellow, NHS Innovation Accelerator Fellows. And in 2018, HaMpton joined the Digital Health London Accelerator. Again, and something else that I was really proud of is that HaMpton was selected as one of the innovations in the NHS to be celebrated as part of the NHS 70th birthday. And I love the NHS. So really to summarize, HaMpton empowers this woman to be involved in their own care, has excellent patient satisfaction, reduces hospital visits, improves the outcomes, and is cost saving. And I'm just going to show you the video by one of our patients.
Okay, my name is Claire Murray. I am 31 weeks pregnant, and I have slight high blood pressure, and I also have, I think, what they used to call in the old days white coat syndrome. So it means whenever I go to hospital or a doctor to have my blood pressure taken, it automatically goes up. So this home monitoring service has been very good for me because I can do it at home in comfort and in much more realistic surroundings. I also think it's good for the people doing it here because it really saves time for both parties. It means I don't have to go to St George's every 3 or 4 times a week, and I can just, as I said, do my blood pressure at home. I record it on a very simple app, and that goes through to some central system at St George's, so it can be monitored. And if there is a problem, I call up. It's very easy. There's always someone to talk to, and if things really get bad, I can be called in. But no time is wasted on either side.
Thank you very much.
Thank you.
Right, good afternoon, everybody. I'm going to start off by telling you about one of my patients because I'm sure it's going to resonate with everyone, whether you're a clinician, a carer, or a patient. So this is Aisha. She's in her 40s. She and her husband have got 3 children, all under the age of 10. She's got type 1 diabetes, which she's had since childhood. And she comes and sees me in clinic once every 4 months or so. She sees my specialist nurse every 3 or 4 months. She has appointments with my dietitian. She comes to the foot clinic. She has her annual eye screen once a year. And this is just her diabetes. So every other appointment is separate to this. Her children fall ill all the time. And every time she has to take a morning off work, depending on childcare, she has to cart her 3 children in the bus across the borough to get to clinic. By the time she gets to see me, my clinic is running late. It's always overbooked. So her sugar's really high because she's stressed. Or she's forgotten to eat before she left home, so she has a low blood sugar in clinic. And when she walks in, all she's thinking about is getting out of the appointment, dropping her children back, and getting to work. And I'm sitting there thinking, what good did this consultation do to any of us? So I work in Newham, which is in East London. Most of our population is from ethnic minority groups. It's a very deprived borough, but it's also a very young borough. It's one of the youngest in the country. So what we have is not only do we have a lot of diabetes in my case, but a lot of our patients are relatively young. But the problems we face, I think, are very similar to problems elsewhere in the NHS. So there's a constant rise in demand. There's a pressure to cut costs and improve efficiency. Our patients think our services are inflexible, they're difficult to access, so they often vote with their feet, they don't turn up for appointments. Patient engagement is poor. And what this means is our outcomes are really not as good as we'd like them to be, I think. So what we've been doing since 2011, and thanks to Penny for pointing out that in 2011 I didn't know how to use a computer, but we've been looking at non-face-to-face care. And just to point out that all our work has been done jointly with our academic partners, Trish Greenhalgh and her team at Oxford. And what we've been looking at is to see if we can replace some of the face-to-face contact with online contact. So in 2011, we were very grateful to the Health Foundation for funding us through the Shine Award. And what we did was a small one-year proof of concept study where all we did was we took one doctor, i.e. me, one nurse, my specialist nurse, and replaced some face-to-face contact where patients didn't require physical examination with an online appointment. And we evaluated quantitative and qualitative outcomes at the end. And we made no changes to the outpatient pathway. All we did was replace some appointments where patients were happy to use it. And we started using standard video conferencing software, so Adobe Connect. Halfway through, people said, well, why don't we use Skype? Because this is what we use socially. So we did a lot of work with our IT department and grateful to the NHS at that time for publishing quick guidance for Skype. And then we started replacing these appointments with Skype and doing some PDSA cycles and refining the pathway. At the end of year one, we thought, hang on, this is service transformation. It's not about the technology. All that technology is doing is allowing us to produce a more flexible outpatient model. So we thought, well, what we really need to do is to co-design a process where we don't give patients appointments depending on our convenience, but we allow them to book an appointment depending on need, and we create a more proactive service. So again, went back to the Health Foundation and got a 2-year program grant. And what we did as part of this was that particularly for people who are serial non-attenders and people who hate coming to clinic, giving them the opportunity to book an appointment depending on need, and then just giving fixed appointments, for example, when people need a diabetes annual review check, and change the process. So I'll show you data in a minute. But as with all projects, you come up with more questions than answers. So at the end of this, we thought, well, okay, this works great in diabetes within my team, but if we were to roll this out across the organization in different specialties, how would that work? So we got an NIHR grant for a project called Vocal. And in Vocal, we chose a surgical specialty, so the HPB cancer team at Barts, which gets people traveling long distances for tertiary appointments, the antenatal clinic, and the overall diabetes service. And we examined online consultations at 3 levels. So the micro level in what does it do to a clinician-patient interaction, the meso level, so all the boring stuff like governance and tariff and SOPs and business cases and guidance, and the macro level in that how does it sit with the ever-changing NHS policy. And this was an action research project, which we published quite a bit about. Just some headlines. So acceptability, up to the age of about 65, 60, it's pretty good. And obviously, we've grouped everybody under the age of 50 together because the acceptability is quite high there. There will always be, we find, about 20% of patients who don't like online care or in whom it's unacceptable. And there will be about 20% of patients in whom clinical needs demand that they come to clinic. And the important thing is you have a flexible approach, even in people who are using online care. So you alternate face-to-face and online, or you mix and match, because obviously you can't examine much online. Our biggest success has been non-attendance rates. So in people who repeatedly use online care, the DNA rates have been coming down quite significantly, and especially where they themselves book an online appointment, there's no non-attendance because they've chosen to book an online appointment at a particular time. Our work was not set up to demonstrate any changes in A&E attendances, so I won't comment on that. And it's reassuring that our marker for glucose control, the HbA1c, is coming down in people who are using online care, which seems to suggest better compliance and self-management. The duration of appointment is shorter, it's more focused, so there's opportunity for increased productivity. The qualitative data is really exciting because apart from the ease of access and convenience, people talk about a change in clinician-patient dynamics and a conversation of equals rather than a doctor talking to a patient. So based on this, back to the Health Foundation, who've been so supportive, and we've got funded the Scaling Up project last year. And what we're doing as part of the Scaling Up work is trying to work with NHS organizations across the country to help scale up virtual care. So we've got what we call a virtual consultation hub within our hospital. We're very happy to support teams nationally. We're working with various outpatient transformation projects because really, I keep saying this, online care is not so much about the technology, it's about making outpatient services, traditional services, which are not fit for purpose at present, more user-friendly. And working with a whole range of national partners like NHS England around tariff and HE around skilling staff and so on. Patients like it. It seems generalizable across age and ethnicity, but you do need a flexible approach, so you've got to mix and match, and it's just one part of the pathway. You do need time to demonstrate quantifiable benefits. The easy hits for us have been things like patient transport, and more recently, we're doing a lot of work around environmental sustainability. The challenges are so complex, I didn't put up a separate slide because I thought I'd overrun. But really, I think the important things for me are to be very clear about who are you offering this to, in what situation, where in the pathway. Be very realistic, because we often have managers saying, oh, this is SIP, and we want to reduce outpatients by 50%. Well, that's not going to happen in the first year, is it? So it's really about managing slowly, gradually increasing demand. Governance seems far better now because there's lots of national guidance. IT remains a challenge in most organizations, so work very, very closely with IT departments. Patients, we're working with people in Norfolk and Norwich, where we thought it would work really, really well because of the distances, but a lot of patients seem to want online care, unlike the people in East London who all seem to want it. We're working with people in Northumbria, where it's doing really well. We're working with Oxford, where the orthopedic team seem to be using it really well. And really important, evaluation, feedback, publication, because as Asma was saying, it really helps to win national awards and get peer review publications. But it's been a long journey, and I'm very happy to take Q&A, but I would say start very small. So we got a one-year project grant for 75K, and now we've got the Scaling Up grant for 500K, but it's been a 9-year journey. And thanks to the team who are not here.
So I'm going to tell quite a similar story, I think, but at the other end of the country. So I work for NHS Highland. And what I hope I'm going to explain in the next few minutes is these two key messages. So first of all, digital services absolutely can be patient-centred. And secondly, that service development really needs to take a quality improvement approach. So I'm going to talk about NHS Near Me, which is our video consulting service. And in really simple terms, this is what it's about. So patients can attend an outpatient appointment either from their own home, using their own smartphone, their own tablet, or from one of our network of local clinics. And we started NHS Near Me in Highland because this is what a lot of our roads look like. So rurality was a barrier for people to attend appointments. It can routinely take someone a 5-hour round trip to get to a hospital appointment, and a lot further if people live on one of our islands. And it's lovely in the summer, and it's not so great in the winter. But very quickly we learned that actually rurality is just one barrier and that there are many other barriers to attending. So you can live in the same town as the hospital, and actually because your physical health, your mental health, because of your caring responsibilities, or indeed having to have a carer to take you to an appointment and transport, there are so many different reasons why it can be difficult to attend. So actually this was not just about rurality, this is about a service change for everyone. So prior to 2018, we had a number of individual clinicians, so engaged people who were trying to offer video consulting for patients on a fairly kind of local level. So it would be one clinician using something like Skype in order to try and offer an appointment to a patient in a rural area. In order to scale that up, we realised we needed to take a more system-wide approach, and so that's what this work was really about. So the development came in a number of stages, and the first one I think is probably the most important, and that was around co-design. So we spent very deliberately 6 months co-designing the service with patients, with clinicians, and importantly with all the staff that are involved in outpatient appointments. And that kind of ties in with the other part of the service design approach, which was taking a systems thinking approach. So really understanding that we needed to embed video consulting into every part of outpatients. This couldn't be a standalone system. It had to be the way that we did business. So we spent the time kind of doing all that design work, and then it was agreed that we could scale it up, which was fantastic. And meanwhile, while we were kind of putting the infrastructure in place to enable that to happen across the organisation, we did a second period of co-design, which was fantastically funded as a Q Exchange project last year. And that was about moving the service to patients in their own homes. So prior to this, we'd kind of taken a clinic model, and this was really about trying to move from clinics to patients using their own devices. And now we're in the kind of the volume scale-up phase. So in that initial co-design phase, as I've said already, it was very much looking at all the different processes. And it was really interesting because to start off with, I'd ask, after every clinic, I asked every patient, every clinician, and all the staff involved for feedback. And to start off with, I got very little. And actually what the clinicians said, and quite quickly, was they saw that what they said resulted in changes, so that the next time they offered an appointment, things had already happened. And the minute they understood that we were really listening and wanting to learn with them, then I started getting 10-page emails telling me all the things that needed to happen, which is fabulous. So we made over 100 changes to the process in that 6 months until we got to a standard process that could be scaled up. That second co-design phase for us was really important, so the Q Exchange project. So we spent a lot of time with a number of patient groups in Skye and really learned from them how they would attend from home. And they made so many changes, again, to the service because of that. So we did some process mapping with them, and we did some workshops, and we got them testing kit and trying to kind of simulate what they would be doing to attend an appointment. And as a result of that, we've made big changes. Like, we have the system open every Friday afternoon for any member of the public anywhere to just try it out. So without that patient involvement, we would not have the service that we have now. So this is the end result of all of that design. So NHS Near Me is a single point of entry service. So this is our website. Any patient, whether they're at home or whether they're in one of our clinics, whatever specialty they're attending, attend via this website, where there's a Start My Video Call button. And when the patient presses that Start Video Call button, the platform that underpins Near Me, which is something we got from Australia called Attend Anywhere, it checks that the patient's got everything in place they need to make the call, so checks their internet connection, checks their device is working properly, and then they enter their name and date of birth. What happens then is they get greeted on screen by a real person, a receptionist, who talks to them as if they've just walked through the door of the hospital. And that was something patients said was really essential to them, to know that they'd got through. It gave them the confidence in using the technology. And the receptionist does everything they'd normally do. They arrive them for their appointment. And the one difference is, instead of kind of directing them to go to a waiting room along a corridor, they move them into a virtual waiting room for their clinical specialist. So I said we've got a network of clinics across the Highlands, and we learned, I think, that not every patient has got their own device, not every patient's got an internet connection. So actually across our rural areas, putting in some local kit for patients to come and use has helped more people use the service. And in all of these locations, the kit is set up so the patient just presses the on button and everything else happens for them. So they haven't got to be kind of technically able to use our kit. A quick comment on standardisation. So for us, to move from kind of a single service level to a scaled up version, we needed to have a standard process. So when a patient is booked against an NHS Near Me appointment type, what happens from that appointment type is a number of things. So first of all, the appointment type triggers a particular letter with all the information about this kind of appointment. It also triggers a text reminder, again, explaining the link that the patient needs to go to attend. The clinic staff in all of our remote locations automatically get a report monthly telling them who's going to be attending at their clinic so that they can plan staffing cover. And then on a daily basis, that report can be run both by the reception staff so that they know who they're expecting, but also by the clinic staff as well. So just by booking against one appointment type, a number of other system-wide things happen. These are all the clinical services that we have providing NHS Near Me. So we've got 31 specialties altogether. We've got a big range of different kinds of services. At one end, we've got some here that are providing 40% of their outpatient appointments this way, and at the other end, it's more like 1%. So there's a range of engagement, but that's where you'd expect, considering where we are in our scale-up journey. These are our data, so you can see very much in 3 stages. Early stage, when our numbers were very small. Middle stage, where we were starting to grow through that implementation and further co-design. And the end stage, where we are now. So we've provided about 2,700 virtual consultations now. I have to mention the carbon footprint. I can't talk about NHS Near Me without mentioning it. So we know that a big cost, particularly in somewhere like the Highlands where distances are long, is either patients or clinicians travelling to appointments. This is a way that we can really address that problem. So I think we need to have more focus on that going forward. But it's not super easy. We've still got some issues. I think that there needs some strategic direction around the fact that video consultations are a way that we routinely provide care. I don't think that's there yet. We still have some services who think it's hard, so we're working on that. And there's 1 or 2 things still to iron out with the appointment booking service. We thought we were there, but then you always kind of hit more problems as you kind of get bigger and bigger. So still some work to do. But when you get it right, this is the sort of story that happens. So this is a patient in Skye who needed to see a consultant in Inverness and equally a specialist consultant in Glasgow. And rather than 2 separate journeys to each one individually, we hooked up a 3-way consultation for that patient, avoiding 2 journeys and having better care as a result. And secondly, another example is a teenage boy in a remote location who for 2 years had refused to engage with any mental health services because he wouldn't go into a hospital building. He was persuaded to attend his appointment from his own phone in his own bedroom, and as a result embarked on a series of treatment with a psychologist and has significantly better mental health as a result. This is just a quick video with a patient view, and then I'll stop.
My name's Annette and I use the Near Me at Wick. It's a wonderful system. It saves an awful lot of travelling and it's so easy to use. A huge difference to me. It used to be a 6-hour round trip down to Raigmore. For an hour's waiting in a waiting room and then travelling all the way back. With my condition, I suffer from fatigue and it would take 2 or 3 days to get over that day, whereas coming to Wick is just so close, can be all done in the morning. Very easy. You just come into a room, sit in front of the camera and speak to the consultant as you would on a normal appointment.
People.
Oh, absolutely. Yes, I think it's the way to go. We've got the technology, we should use it.
Thanks very much.
Thank you. So 3 presentations there around successfully implementing new technologies, better outcomes, better patient experience, lower costs, what's not to like, and why aren't we doing this everywhere? Well, we're going to spend a bit of time now just perhaps reflecting in a bit more depth around some of the challenges and hopefully some practical tips as well for you if you're thinking about some of these innovations, implementing them in your area. We're going to have a bit of a chat, and then I'm going to open it up for questions from the audience. So do start thinking now if there's some specific areas you would like to probe on. We're really keen that you walk away from this session with some practical ideas that are meaningful for you in the work that you're doing. So I want to start with this issue around co-design, because part of what stood out to me from all of these presentations was that the experience of the people using the service was at the heart of the work that was being done, which was lovely, really lovely to hear that. And none of them saw this as a implementing technology change. It felt like this was very much a redesign piece of work that was digitally enabled. So I just wonder, perhaps turning to the speakers, how important is that, do you think, for success? And were there any particular techniques you used, any tips that you would give our audience today about how to make sure that that user perspective is embedded into the work?
Should I start? Yeah. Yes, I mean, absolutely. And PPI, or the patient involvement is almost essential part, not just for the research or putting applications or grants on, but actually everyday life. I mean, I work as a doctor. I face patients every day. It's just part of my everyday life. And but what's really important is that this is something that they will use, so they have to be comfortable. They have to like it. And the other thing is that when you are doing it, so how do you do it? You could do it just by asking the patient that they're actually using the system, or you could be more sophisticated and say, well, we're going to have a sample of, let's say, 25 patients, and we're going to have 5 patients from each ethnic background, because we want to make sure that this system is not just fit for, Caucasian, middle class, English-speaking people, and you want to make sure that it's used or can be used by everybody. So I work at St. George's. It's about half of our women or pregnant women who book with us come from non-white ethnic backgrounds with different level of socioeconomic class. And therefore, we wanted to have a sample that's representative of our population. And therefore, this system can be used by all women. Obviously, the thing about the English, which is something that we are working on, is to be able to have it in a different language. But so far, it's just English. So how do you do it? I think try to be a bit more sophisticated. It doesn't really take much more effort to just make sure that you have a representation from different backgrounds. And then you have to have it's like a team effort, really. So you've got the stakeholders, and patients is equally important. It's important as a software developers, it's important as a researcher, it's important as a clinician. And having a dialogue conversation. So when they say, well, actually, I'd like it when you have an alert, I'd like it to be red. The color of it is red because that's alert. I like it to be like the traffic light. When you have a green, which is good, the measurements, the blood pressure readings are fine. Yellow or orange when it's maybe borderline, and red when it actually means that it is abnormal. So, we took that on board, and that was not difficult to implement. So just working with people, and I said that you really find very useful comments, suggestions.
So I think you have to do it. I just think you can't create a service without having the people that are going to use the service being involved. But I think it's not just the patients. I also think all the staff are important too. I think we're actually quite good at co-design with clinicians. We're getting better with patients, but we forget the staff, who are actually really essential to making things work. And the biggest thing I would say is you have to just embrace it. You have to accept that what you've got to start off with is not right. And don't be precious about what you've got. Accept the fact that people are going to come up with lots and lots and lots of changes, and you go with it and you test it with them and work through the process with them. And in terms of how you do it, I mean, we we had groups, so I went to public events, so I went to community councils, I went to different kind of groups within the community in order to try and engage them. We held events as well to try and bring people in too, so that they could come in and learn about what we were doing and then sign up for our groups. And then we had individual focus groups, one-to-one interviews, kind of, and just feedback after every session. But really simply, just be prepared to change. Don't be precious about what you're doing.
Great, thank you, Claire.
Yeah, just adding to what Claire and Asma said, I mean, in terms of co-design, absolutely agree. Patients, carers, staff, and all the people that I'm guilty of never involving. So, you know, the appointments clerk and scheduling, the IT help desk. I mean, you know, all of them are absolutely crucial because, you know, the chief executive might go around talking about how wonderful the project is, but if you don't get the scheduling team on board, you're never going to get those appointments rearranged. So it was really quite important for us to get multiple workshops with various stakeholders to try and sell the idea and get feedback. And the patient bit, what I found really useful was it destroyed a lot of myths and stereotypes. Mm-hmm. So I provide an adolescent diabetes service, and I thought, you know, that's going to be easy. It's the older people with long-standing diabetes who probably won't use online care. But actually, a lot of our patients are 80. So, you know, and then the cancer team had a real concern about breaking bad news online and thought it could never be used in liver cancer services. And we were quite surprised when one of the patients said, look, I'd rather you broke news when I'm at home and then I could just cry and go and have a cup of tea rather than come to your clinic, you tell me bad news, and then I have to make a 2-hour journey on my own or back home. So I think it was really useful for us to talk to a range of people because it destroyed a lot of our perception.
That's great, thank you, Shanti. So you've talked there about the role of co-design and design thinking in supporting the implementation. What about QI? How did that help with the implementation of the change?
So for me, it's been, I always said I was terrible at QI. I think I still am, but it's at various levels. I think it's been using a lot of the kind of usual QI principles. So starting small, being very clear about what's your population to target, what are your outcome measures, not being very ambitious and ticking all the boxes, but looking at what are the key deliverables, getting it done on a small scale, doing some PDSA cycles, ironing the faults, then rolling up a little stage further, evaluating at every step, getting lots of feedback from staff and user groups. And then once you think you've got a rough model and you've evaluated it, rolling it out slightly wider. Mm-hmm. And then, as I keep saying, we realized it wasn't about the technology, it was redesigning the service. And so once we tested the technology and thought it was fit for purpose and it was feasible, we then had to look at redesigning the outpatient pathway to make the technology fit for purpose. And so that involved a lot of co-designing different parts of the pathway, mm-hmm. and using, you know, driver diagrams and delivery targets and Gantt charts to make sure we're meeting outcomes. And it does help that you always have an external funder, so you're bound by targets and deliverables. Mm-hmm. And then at each stage we had a dissemination event and lots of workshops with commissioners and trust board and various teams within the trust, and then rolling it out further within the organization, and then now nationally. And now we've got a national Slack group that we use to create a network, and we have an online directory of service that we post questions, and we've got a kind of peer network of people who are all doing the same thing. And we keep having these national meetings to share learning and feedback and vent frustration.
It's amazing, isn't it, how it started so small and has really grown. And Shanti, I loved what you said as well about being realistic, because one of the things that they said at Microsoft about why they failed the first time they tried to go into healthcare, it wasn't just that they underestimated the complexity of healthcare. They said it was healthcare significantly overestimated what could be done in what timescales. So just that level of being unrealistic in healthcare, and I'm sure that's just the American context, that doesn't happen in the UK context. So now they're entering in and I think trying to be much more realistic about this. This challenge of spread, and it's such a big one, and it's been talked about already this morning, the fact that you can't just lift and drop changes into different contexts. And I suppose I'm interested in, what does adapting into the local context look like in terms of the work that you've been doing? And Claire, you know, you've rolled this out across the whole of Highland, which is a large area. Yeah. So could you talk a bit about some of those challenges of how what you have to do to get it to work in different contexts?
So across Highland, but also the process has been shared across Scotland as well. And actually, I think that's what it's about. It's about understanding that there are a whole number of different things that you need to think about when introducing something like video consulting. And it's about providing other people with the kind of that framework of these are all the areas you'll need to think about. So you're going to need to think about appointment booking. That's an important area. Now, how we do it is this way for this service, but actually for another clinical service, well, how they book appointments will be a little bit different, so they're going to need to adapt it, but it's the same topic area, the same process that they need to go through. So actually you can enable it much faster in other services because they've got that framework to start from, so they can work through, okay, these are all the areas. So we have a 40-page document with all the kind of different things that you need to think about, and that then has enabled other people to move much faster as a result, which is really what it's about, isn't it? You can't just lift and stick. It'll never happen. But that understanding really gets people moving faster. And
is that 40-page document available?
It's been shared across the whole of Scotland, and it's gone to the NHS Improvement NHS England team who are supporting the Attend Anywhere pilots in England as well.
Great. So if folk contact NHS Improvement if they're interested in getting hold of it. Yeah. Fantastic. Or obviously, it's already been shared in Scotland for any Scottish colleagues here. Yeah. Okay. I think we'll open it up to questions from the audience now. I don't know if we could have the lights up. Great, hands up already. So we'll start with colleague there. Yes, yourself.
Hi, my name's Graham Hinchcliffe. I work for a healthcare consultancy called Mango Tree Group. I work into lots of different NHS trusts. I thought that was really interesting. What I wanted to ask about was app development and some of the barriers that you might have faced. I know within some of the organisations that I've worked, it's quite difficult in terms of getting a business case together and then having to approach app developers as well, and which one's going to be the right one, and everyone has to have a fair pitch in terms of the selection process. How do you know what the product that you're going to get back is what you want? It will work the way you want it to, and also sort of confidentiality and data issues. Is there anything that you could just sort of advise around those areas, any of the barriers you face and how you overcame those?
Okay, and before we look to answer that, I'm just going to take a couple more questions so that there's a 3 that we're going to answer in one go. So your colleague next to you, and then I think there was a gentleman just behind as well.
Hi, thank you. Ian Holt, nurse academic at Plymouth. Question really for Claire about rurality isolation. So we're driven with EPIC a move towards the similar approaches that you're taking. But in my widening engagement lead, I find a number of people who enjoy appointments, they enjoy the travel, they enjoy the pickup, and it is their opportunity to move out of isolation. So.
Great, thank you. And then the colleague behind.
Hi, nice to see an all-female panel on technology. It's really an expansion on this, the collaboration with private sector and usability of tech. I think it's an area that clinicians are frightened of, and just the experience of working, designing technology together with private companies in an area where there'll be more collaboration in the future. Just some comments on your experience.
Great, Thank you. So, over to our panel. You can answer them in whatever order you like.
I mean, it's a question about the app. And when people present, they talk about their achievement. They don't talk about a lot of the problem that they had to go through. And so I said, I'm a doctor, I'm a clinician, so I don't really have, or I didn't have any experience with which company to go for. And over the last, let's say, 4 years or so, I learned so much. I learned about business, I learned about technology, about the regulations, about the NHS requirements for digital innovations. NICE, I also did NICE fellowship for 3 years. That was many years ago. But so NICE have published in March this year a document for a framework for digital innovations. And it does actually specify what level of evidence, so to actually, if you develop a digital innovations that you want to introduce in the NHS, but also does provide some useful information about what the digital innovations itself need to fulfill, what requirements. Obviously, this is something that's developing every day in terms of the NHS platform, the G-Cloud, the FHIR platform, what the sort of system they need to link. So, for example, if you have an app, your hospital would say, but I'd like to have this information feeding into your existing electronic, the EPR, for example. There's a whole thing about Cerner, and Cerner might not necessarily want to connect with your small app development company. So, it's a very big word. I'm certainly happy to follow up that with you and say what we've done and what we've learned and what I would suggest or recommend for you that you should do. My suggestion is to go actually to a company or software developer. So I really agree with your colleague behind you who said that you have to work with private companies because, let's face it, the NHS we don't really have the digital technology to develop apps. I don't think so. I think you have people who are this is their expertise, and you just need to select the right one that have track record of producing material or digital innovation that can work in the NHS. And the regulations are going more and more stricter, I think.
Great, thank you.
So just about your question about working with technology companies. So we started off using Adobe, and then our patients said use Skype because that's what they used. And so for about 4 years, we were just using Skype. And then our trust went down the VDI route. And of course, consumer Skype doesn't work very well on VDIs. So we started working with Microsoft, and who are our partners on the Scaling Up project. And we were looking at Teams because we just thought, since we were all going down Office 365, we would get Teams, and that would be great to just use for video consults. But you realize you have to do a lot of work to make what is not a patient-centered tool fit for clinical purpose. So it's been a labor of love on both sides because, just silly things like double booking appointments, and even forget a small company, even Teams doesn't integrate with Cerner, which is what we use as electronic patient record. So we've been spending so much time just trying to integrate it. When we were contacted by NHS Improvement to ask if we would be a pilot site for using Attend Anywhere, which is what we're using now. We're trialing as well because we think that replicates an outpatient process, but you have to buy licenses for Attend Anywhere. So unlike Scotland, which I'm always very deeply envious of, once we get past the initial pilot phase, we will have to pay for licenses for Attend Anywhere. And there isn't a national policy at the moment about central procurement or who's going to fund these licenses and how many licenses and all of that. So I think coming back to challenges, unless there is central guidance and a strategic direction about what a centralized process is going to be like, a lot of us are going to be doing it on small scale, replicating it elsewhere. But the optimist in me thinks that if a lot of us just change the outpatient process, then whatever tool we have will just facilitate it. So it's getting the process right and using the technology as it develops to strengthen it, rather than building it around the technology, I think.
Thank you, Shanti. And Claire?
I'll just comment on that, and then I'll answer the rurality question. But yes, we're very lucky in Scotland. So Attend Anywhere was procured nationally for all NHS boards in Scotland to use. That does put us in a good position. But actually, to really drive the financial benefits, which is what will be required in order to pay for the licences, we do need strategic direction and a lead, a kind of a national level to say, video consulting is the way that we will now offer consultations. Obviously not when there's a clinical need to see a patient, and our services has been entirely driven by clinicians having that decision initially about, do I need to see this person in person? Do I need to lay my hands on this person? Do I need to provide a procedure? Clearly then those patients will be made a face-to-face appointment, but it's all the others, and we haven't got that kind of at a national level. So actually that could be UK-wide. So that's one thing. But the rurality question, so here's an interesting observation. In November and December, we see a reduction in the number of people wanting an NHS Near Me appointment, and that's because they like to come and do their Christmas shopping at the same time as their hospital appointments. So yes, you're absolutely right. I think there's a challenge and an opportunity. So I think we are going to get to a point, I'd suggest we were at it now, where from an environmental perspective, we have to stop unnecessary travelling. So where there isn't a clinical need to travel, why are we travelling? So actually that should be driving this from the rural areas. But actually video technology provides an opportunity. So there's a fabulous project in the North Highlands called the Dementia Friendly Communities, where they bring together people from all over the place into a group space to get the social interaction. So by these screens, which are in community hubs in villages, but also for patients in their own homes as well, they bring together people to do things like crosswords together, to have music together and so on. So actually we can address the rural isolation in a different way by using the same technology and cut all these journeys.
Thank you, Claire. And good news, Claire, the national approach in Scotland to Attend Anywhere is on its way. So that one hopefully will solve soon as well. I think we've probably got time for about one more question. So I'm going to go to the lady in the pink because she got her hand up first there.
Hi, thanks for that. I do dermatology, so actually video is really good because sometimes you don't actually have to touch the patients, you just use your eyes. You're all really enthusiastic and I love it, but how did you get laggards who pretend they can't even order blood tests online to do this? Where's my registrar? I can't order that test. And it's just so much easier to get the patients back. How did you deal with your laggards?
So I would say we haven't got them all yet. Actually through demonstration. So trying to get people to enter both as a patient and as a clinician. So actually to sit down with them, give them the device and say, "This, let's have a go, let's do it together." And actually, because it's so easy, so the platform helps us, the waiting room function really helps us a lot. And when they've seen it, a lot will come on board. Our number one clinician for providing video consultations, when he started, he said he was doing it for one patient in one remote area, and that was it. And actually, we've seen him just grow and grow and grow and grow as a result of just how easy it is to use. So I think the only way you can do it is through demonstration.
I would say start with the most enthusiastic people. So always, it's good to have a success story. So we started with the people who were quite enthusiastic about it, and then once they started doing it and demonstrated it to others, we also made lots of very powerful patient video films, because I think for clinicians, I'm going to upset all the managers in this room, but if a manager came and said to me, "You need to do this because it's a SIP and you need to reduce this and we need to make some cost-benefit savings," I would just switch off. But if a patient came and said to me, what a nightmare it was, then I might listen. So we did some very powerful films of patients talking about their experiences and the challenges they faced. And then we kept playing it in various workshops and study groups and so on, and saying, "Look, this is the impact it's having on people's lives. Do you want to give it a go?" And that seemed to work.
Great, thank you. And so before we close, I'm going to ask our presenters, if you were to send the audience away with just one thing to remember about how to do digitally enabled service transformation, what would it be? What's your top tip, your one thing, if you just remember one thing from this talk, remember this?
I would say listen to your patients, because that's the most powerful tool. I think it works on various levels. So A, it helps convince staff, because staff always respond much better to patient feedback and patient stories. It also helps hugely when you're convincing others who don't deal with patients. So we used to have a huge problem with our scheduling people, changing clinic templates to use the web appointment, to put the web appointments. So when chocolates didn't work, I actually went and started talking to the people in the scheduling office to say, you know, you changed those templates in that clinic. It's made such a difference. And this is what this lady said to me the other day. And so it actually brought the problem from being something some stroppy clinician was asking about changing templates to I actually helped that lady keep her appointment. And also it's really good for commissioners in general. So every time I go and scrounge around for money, I always start off with a patient video and end with a patient feedback thing at the end. And then suddenly everybody's not so angry anymore.
Great, thank you.
I guess my message is that don't be afraid of trying something new. And even if it sounds difficult and say, oh, I want to do that, I'm not sure what to do and what regulations, other people have been through this and they managed to overcome it, and you can, and the reward will be at the end of the road.
And I'd say it's not about the technology, it's about the processes and it's about how it's used. So involve the patients, involve everyone, think about your entire process, never think about technology in isolation. So preferably don't get someone with technology expertise to lead the project, because they'll be too focused on the technology. Get someone who understands the systems.
What fantastic advice. Thank you so much. And for those of you who didn't get to ask your questions, please, we're going into lunch now. Do come and catch people individually and let's carry on this conversation. Thank you.